So, as Rachel mentioned, I'm going to be talking about quantifying and identifying opportunities to reduce hospital activity and shift care to the community. So this is work that I've done in the strategy unit alongside Anya Ferguson, and then this was managed by Justine Wiltshire as well. So what I'm going to talk about today, it's actually a report that we've produced that is readily available online for anybody to use. And so basically what I'm going to do today, I'm going to give you a few of the key findings from that report, very kind of high level, because there's a lot of information in it. But also I want to kind of just give you a bit of a taster of the report, the kind of information that's in there, how it can be used. Because as I said, there's so much information in there and it's really been designed for people to go, if you're interested in this kind of thing, and have a look at the information that's in there and if there's anything that might be useful. And as Rachel mentioned, I'm happy to take questions, but also we'd really welcome any kind of input in terms of things you might like to see, information you might like to see in this type of report, or any ways you think you might want to use it in the future. Because although this kind of version of the report is finished, within the strategy unit, we are doing more work related to this. And I think Claire from our data science team might speak for a few minutes at the end about kind of the future of this work. So any kind of input would be most welcome. Okay, so hopefully, actually, lots of people came to the Huddle 2 weeks ago, where Faiza Bhatti gave a really good talk about this whole idea, actually, of switching care from acute hospitals into the community. And that was a perfect introduction, actually, to what I'm going to talk about today. But just as a brief introduction today, I'm sure most people are aware that last year, the government released their 10-year plan for the NHS in England. And one of the key parts of that report was around this idea of trying to shift care from acute hospitals into the community. And within the report, it mentions things like shifting the pattern of health spending. So at the moment, the vast majority of spending is on acute hospitals. And if you're going to move activities to the community, you need to also shift that pattern of spending. And also there was mention of local areas needing to build and expand their neighbourhood health services. So to actually achieve this, we kind of need evidence and we need analysis to kind of inform those decisions in terms of what's needed, in terms of the shifting of resources. So we need to know what sort of activity it is we want to move from acute hospitals, what sort of community services are needed to meet that demand, what kind of patients and conditions they'll need to manage, and what the kind of volume of activity is. So that's kind of where we came to it. We wanted to start doing some analysis, start providing some information to inform that kind of decision making. So the way in which we've kind of approached this is by using the concept of potentially mitigable activity. So the idea is that shifting to care into the community assumes that there's subsets of hospital activity that can be mitigated or avoided by the use of greater use of existing community services or by new services. And so actually the strategy unit, as part of the new hospitals programme demand capacity model, has actually developed 92 categories of hospital activity that could be defined as potentially mitigable. And this idea of potentially mitigable activity is actually really useful for doing this work, because we can't actually directly measure the activity that's avoided. The avoided hospital activity is obviously an unknown, but what we can measure is this potentially mitigable activity. And when we talk about this activity, we're not saying that all activity in these categories of potentially mitigable activity can be avoided. It's only going to, in practice, be a proportion of that. But that if hospital activity is being avoided, then we should see it within these categories of activity. This is the type of activity that should be reducing. So we had three key aims with our report. Firstly, we wanted to try and understand the scale of potentially mitigable activity to inform prioritisation. So the idea being we wanted to understand which of these categories or types of potentially mitigable activity have the highest volumes, because those are potentially the areas where you can have the biggest impact. We also wanted to track trends over time to indicate whether there has already been any shift away from acute hospital care towards communities, or at least provide a baseline with which we can track activity going forward. And we also wanted to provide a comparative analysis. So we wanted to look and see, is there different effects in different areas? Are some areas seemingly performing better than others? And can we identify those areas and potential opportunities to learn from what they might be doing? So in terms of the methodology, really high level. So the data that we've used within this report comes from the hospital episode statistics data, so it's inpatient data. And what we've done is we focused on 29 categories of potentially mitigable activity that are related to community care. So of those 92 that have been developed, we've focused on 29 within the report. If you're interested in exactly the kind of activity in each category, the code to define these groups is available on the strategy unit GitHub page, and we can share that afterwards. But that will give you exactly what codes the inclusion and exclusion criteria for all of the different categories. And then what we've done is we've analysed all the admissions in England that met the criteria for one or more of these categories of activity. So this is a really kind of high-level summary of the 29 categories of activity. So they're basically all of these different categories, or we sometimes call them types of potentially mitigable activity, are grouped into 4 different mechanism groups. So we have a group which are the redirection and substitution group. And so the way that we think that activity in this group would be reduced is through greater use of primary care or community services. And so this includes types of activity such as end-of-life care, frailty in older people, ambulatory care sensitive admissions, emergency readmissions, and medicines related admissions. Then the second group is the prevention mechanism group. So this is more focused on public health initiatives to try and reduce activity. So things around reducing smoking, obesity, alcohol consumption, and also supporting mental health. Then the third category is relocation and efficiencies. And these are, this is basically to do with the use of virtual wards for things like acute respiratory conditions and heart failure. And the final category is efficiencies. So this includes things like emergency admissions of older people, stroke, and admissions with mental health comorbidities. So the efficiencies group is somewhat different to the others. The first 3 groups, the idea is that potentially the admissions could be avoided, and through avoiding some of the admissions, you would then reduce bed days. However, the efficiencies is a little bit different. So with efficiencies, we don't think that the initial admission could be avoided, but rather there's the potential to reduce length of stay and reduce bed days. So efficiencies focuses purely on bed days, whereas the others, we look at both admissions and bed days. There's a couple of key points in terms of these different categories. So the categories are not mutually exclusive. So you'll see in some of the data I'm going to show later, but basically you can have an admission that would say fall within the ambulatory care sensitive category, the smoking category, and the acute respiratory category. So it's not as simple as just summing up the numbers in all of these to get a total count of activity, because you'll end up with double counting. And so for this reason, we have provided some summary pages. There's one for each mechanism group, and then there's an overall summary. And within those, we have taken out any double counting each admission in those summary pages is only included once, just so you can get a bit more of an idea of the total activity. And also, we're not saying that all the activity within these groups could or should be reduced. We're talking about a relatively small percentage, maybe say 10 or 15% of the activity in some of these groups that could be reduced. So this is actually our report. I put the link at the top, but again, we'll share it in the chat and after the huddle today. And I'm just showing here the user guide. You will see there's a lot of information within the report. There's a lot of pages. There's 29 pages, one for each of the categories within the report, plus some summary pages as well. But each page in the report follows a kind of a similar pattern in terms of giving some descriptive analysis to understand kind of characteristics of that cohort, what kind of patients and what admission characteristics are in there. It includes some cohort overlap to understand which of these cohorts categories are overlapping, some comparative analysis, and also trends analysis as well, which I'll talk about in more detail. But I just wanted to start by giving a kind of idea of the scale of the activity. And this is for the whole of England for 2023-24, which is our most recent year of data. And here we've got all of these 29 types of potentially mitigable activity and the number of admissions and bed days. So as I say, these are really high numbers, but that's because it's everybody within those categories. So for example, at the top here, you've got emergency admissions of older people. So this category is actually all emergency admissions for those over the age of 75. So it is a large category, and we're not saying we'd reduce all of that, but that a proportion of that could potentially be reduced. So you can see here the kind of activities that are high volume. So they are emergency admissions of older people, frail older people, those with high and intermediate frailty scores. There's admissions with mental health comorbidities, emergency readmissions, and ambulatory care sensitive admissions as well. And these are some of those kind of higher volume ones. And so I think those are areas where there's a lot of interest because there's a lot more scope here to have an impact in terms of shifting activity because the volumes are so high there. So I'm going to start by talking a little bit about the first two sections of the report, kind of who is in these cohorts and what are the admission characteristics. So as I said, this is really just a taster of what's in the report. There's lots of other things I can't show today, but I just wanted to give you a few kind of examples of what's in here. So in these demographic and in the cohort overlap sections of the report, the data is for the whole of England and it's for the most recent year of 2023-24. Here I'm just showing some examples for chronic ambulatory care sensitive conditions cohort. So on the left, we're just showing the percentage of these admissions for this cohort that are within each age group. So here you can see that admissions are most common in those aged 75 to 79. In fact, if you add up all these percentages at the end here, you can actually see that it's around 40% of all ambulatory care sensitive admissions are in those over 75. So we present the data as percentage, but we do also present it as crude rate. And here I've shown the crude rate for IMD decile, so index of multiple deprivation decile. So here on this chart, we have IMD decile 1, which is the most deprived areas. And you can see the rates of admissions from those areas are much higher if you compare it towards the more affluent areas. In fact, the rates are double in the more deprived areas compared to the least deprived. So we also include information on sex and ethnicity as well here. And we do all of it by both admissions and bed days as well. So we also include the 10 most common primary diagnoses codes within the chronic ambulatory care sensitive cohort. So Here you can see, for example, that chronic obstructive pulmonary disease is actually the most common diagnosis within this group. About a fifth of the admissions are for COPD. Also, there's a high proportion of admissions for heart failure and asthma. So again, this is just to kind of give you an idea of who it actually is in this group. What type of conditions are we talking about? And again, within the report, we also give a breakdown of the length of stay within the cohort. So you can see here for chronic ambulatory care sensitive admissions that actually about 25% have a 0 length of stay. So that means no overnight stay. They're admitted and discharged on the same day. So this might indicate that perhaps these are a proportion of these where the activity might be more amenable to primary care and community services because they're not, they haven't got those longer lengths of stay. Whereas we do also see some longer lengths of stay as well. In fact, it's about 25% of the admissions actually have a length of stay of greater than 1 week. That's just to try and understand who's in the cohort. But we also have information to kind of understand how these cohorts fit together. So this is basically just to show the number of different cohorts that those within the chronic ambulatory care sensitive cohort are within. So actually it's only around 16% of this cohort are purely in this cohort. So the other 84% are in multiple other cohorts. Around a third are in one other of our 29 cohorts, and just under a third are in 2 of our other cohorts as well. And this is only the 29 community focused ones that are included within our report. So again, as I said, it's important to kind of understand this overlap and that you can't simply add them together, and that any kind of targeting of one of these categories may well impact on the others as well. And we do go on to show a little bit more information as well about the other cohorts that kind of overlap. So again, you can get a bit more of an idea of the types of admissions here. So as I showed previously, about 16% are purely in this cohort, but actually there's a lot of overlap with the virtual wards, acute respiratory infections, a lot of overlap with emergency readmissions, with frail older people, heart failure virtual wards, and with smoking and obesity. So it gives you a bit more of an idea of that kind of overlap. So now I'm going to move on and talk about whether potentially mitigable activity is actually reducing, and whether there are differences in activity between regions. So this is again national data, looking at this time, it's looking at hospital activity for end-of-life care. And here on this chart, we're showing the standardised rate of its age and sex standardised rate per 100,000. And this data is for admissions. So we've got data over the last 9 years, we've compared over the last 5, and we can see that for end-of-life care, that we've actually seen a 23% reduction in admissions. So that kind of suggests that in terms of this activity, there is some kind of shift towards community activity, and more people are being cared for at home or in hospices rather than in hospital. Moving on, looking at some of those other categories of activity within the report. This time I'm actually showing bed days rather than admissions. And again, it's this standardised rate. But you can see here, as I talked about, chronic ambulatory care sensitive conditions, actually the rate of bed days has increased by about 19% over the last 5 years. For acute alcohol related bed days, there's been a very large 35% increase in those. And also for frail older people, so that's those with a high frailty risk score, the number of bed days, the rate of bed days has increased by about 10%. So not only can we look at these kind of national trends, but we can break down our data. So here I'm showing the age and sex standardised rate of bed days for frail older people by ICB area. So this is actually just the most recent year of data we've got, 2023-24, and their standardised rates in this year. So you can see there is considerable variability in the amount of activity between different areas. If you look on the map and on this summary chart here, you can kind of see there's higher rates, particularly around some of the larger cities, so Manchester, Birmingham and London, whereas other areas have got lower rates, such as, for example, Cornwall. So within the report, you can look by ICB, but we do also have data broken down at other geography levels as well. So we do have tables within the report that give data at the local authority level. So these tables, you can search them and you can order them. So for example, here I've ordered it so that you can see these are the local authorities with the lowest standardised rates of bed days for frail older people. And you will find for all of the data, we give both the raw numbers and we give a percentage of the admissions as well as the standardised rates. And also for these tables, because it's designed to kind of be used for different uses, you can also download the this data as well if you want to play with it yourself. And we also have data as well now at provider level as well. So here you can just see I've searched for Dorset, so it's brought up the Dorset ICB area, and here you can see the different providers within the ICB area, and you can compare the kind of rates between different providers as well in the tables. So not only at these kind of breakdowns can we look at the rates of activity within the most recent year, but we can also look at changes over time in activity. So here on the left, we're showing a data that summarises the change in admissions over the last 5 years, and on the right, the change in bed days. So if we start by looking at admissions, in England overall over the last 5 years, there's been about a 1% increase in admissions for frail older people. And you can see around half of the ICBs have seen an increase and around half a decrease in admissions. And I've just highlighted here Cornwall and the Isles of Scilly. They've seen a particularly large decrease in the number of admissions, so about a 23% reduction in admissions. But actually, if you look at bed days, you see a kind of a slightly different view. So as I've shown previously, the England average increase in bed days for frail older people is around 10%. And you can see here there's a lot more ICBs are seeing an increase in bed days. There's only a few here that have managed to reduce bed days. And again, I've highlighted Cornwall here just to show that actually, although they're below the England average, they've actually seen an increase in bed days of about 8%, despite having a reduction in admissions. So it is kind of important to kind of look at the two together, and it's not quite as simple as just a reduction in admissions going to have an impact on bed days. And obviously, when we started kind of looking at this, that kind of led us down the idea, well, clearly something's happening in terms of length of stay for these kind of cohorts. So we have added more analysis as well that looks at length of stay. So again, the example of frail older people admissions. The chart on the left gives the data for England as a whole for this cohort. And what we can see is that for the shorter lengths of stay, so for no overnights, these are the yellow, orange, and also the red lines. So for no overnight stays, 1 night or 2 to 7, we're actually seeing a decrease in the proportion of those that for frail older people. However, for those longer lengths of stay, we're actually seeing that the greater proportion of those are for frail older people. So we've got more frail older people admitted for 1 to 2 weeks or over 2 weeks. And again, within the report, you can have a look at the average length of stay at an ICB level and a local authority and a provider level as well. So here, when we look at the average length of stay for frail older people, we can see that actually the England average has increased, as you'd expect, perhaps from the previous data, by about 8%. So we're having these longer lengths of stay. And again, you can see, and that's consistent across a lot of the areas. There are some areas, though, that are managing to reduce their length of stays. So when we start thinking about changes over time, obviously we can look at how much an ICB area, for example, has changed. But actually, how much they've changed may well be impacted by their starting level of activity. Those ICBs that 5 years ago, for example, had high levels of activity will have had more scope to decrease them. And those that had a lower starting level will have perhaps had less scope. So it's not quite as straightforward as just looking at the percentage change. It's also interesting to see, well, what was their starting level? So we've included these quadrant charts within the report. So what we've done is we've plotted the change over the last 5 years, the y-axis, and then along the bottom we've plotted the standardised rate 5 years ago, so for 2018-19. And then all the ICB areas are plotted on these. What we show here is in this bottom left-hand quadrant that's in green, any ICBs that fall within this area are those which started with a below average standardised rate of activity 5 years ago, and despite already having a low rate of activity, have managed to reduce their activity further in the last 5 years. So ICBs that fall within this area, so for example here Bath, North East Somerset, Swindon and Wiltshire, could be perhaps considered as some of those top performing areas, given that despite their low rates, they've managed to decrease further. So this is just another way that in the report in which you can look at that change over time. So just to kind of summarise some of our key findings from this work. So for a few of the categories of potentially mitigable activity, we are actually seeing shifts away from hospital care. So, for example, I've shown you for end-of-life care, we are actually seeing those decreases, which suggests that obviously activity for end-of-life care in hospital is reducing due to greater use of hospice or care at home services. However, for many categories of potentially mitigable activity, acute hospital care is actually increasing. We're not yet seeing any kind of a decrease, and we're seeing increases particularly for things around high frailty, chronic ambulatory care sensitive conditions, acute alcohol related admissions as well. And we do see considerable variability between areas in terms of both the current rates of activity and how they've changed over the last 5 years, which does suggest that there are areas that appear to be performing better, and this kind of provides a starting point kind of for future work to try and really identify those areas and look at whether they're doing things in there that might be possible to implement more widespread. And then again, as I've shown, for some activity, we're actually seeing trends towards increasing lengths of stay. So when we think about strategies to reduce hospital activity, there's a balance required between reducing admissions and also reducing length of stay, and a need to consider both of those together. It's not simply enough to try and reduce admissions. So those are kind of some of the key findings from our report. But really what it's been set up to try and help ICBs, providers and others to kind of understand where there might be opportunities to reduce inpatient activity and the kind of scale of those activities. Also to try and indicate systems that are potentially performing well, where there might be opportunities to learn from them. And also to provide a basis to start informing decisions about things like shifting funding from acute services to primary and community care, or about the types of community services that might be needed. So that's just really kind of a brief overview of some of the things that are in the report and some of the kind of ways the information can be used. I'm happy to take any questions or any feedback on it. Again, these are the links to both the report, Also, all of the code for generating the report is available on the GitHub page for the strategy unit as well.
It's great. We've got thumbs up all round, Sarah. Thanks very much for that. No, that was great. We've got several questions on Slido which I'll share. But before I go to that, let's see who has their hand up in the room. And we've got a couple of people. Either they're saying well done, or which sometimes happens. I've done that so many times. Or Joseph, do you have a question or a comment for Sarah?
Yeah, firstly, thank you very much. It was really excellent and really great piece of work. My question was around the choice of activity. So I know you said you did 29 instead of the 92. And was that down to a kind of a feasibility around what data was available, or was it down to a kind of a choice around particular data sources?
So the choice was around, we wanted to kind of focus for this on those that are community related activities. So for the other 92, some of those are more related to, for example, A&E attendances, or they're more related to kind of hospital activity that might be reduced within the hospital. So around kind of some of it's more outpatients, some of it's procedures of limited value. So these were the ones that were kind of identified, these 29 as being ones that kind of had a real focus in terms of community and primary care. So that's why we chose them. Although we would have liked to include some of the other ones, but the data was already massive as it was. So
thanks.
Thanks, Sarah. We've got a question also from Danielle.
Hello,
Danielle?
can you hear me? Sorry, can you hear me? Oh, great.
Yeah. Go ahead.
Danielle Wilson, Deputy Head of Business Intelligence within Cheshire and Merseyside ICB.
Right.
That was a really helpful presentation, certainly how it's set out, and I really liked how you've differentiated the 29 conditions that you've looked at into the 4 different categories. I think that's so helpful, particularly when you're looking at that double counting and how to take some of that into account. So it's really helpful, and I'm looking forward to getting access to the report to see what we can adopt locally. One question I had, and it's not particularly for you, it's for anyone on the call really, just using this forum just to share ideas. When we've looked at this locally, what we're finding, and I think it was demonstrated on the ACS slide that you showed, in that kind of high proportion of short stay, so 0-day length of stay. And what we've looked at is it's largely patients who are self-presenting to A&E. So it's the A&E attendants. And I just wondered, we have focused largely on once the patient's admitted, and I just wondered if people are aware of any work that's specifically done with avoiding that initial A&E attendance, and so the patient isn't even then being admitted and obviously staying inappropriately. So yeah, it was just for any thoughts or feedback on if people are aware of that. I know that's a much harder cohort. But yeah, I just wanted to kind of open that question up really.
Sarah, have you got a view on that, or should we just leave that open and see if anybody wants to? No, that's a good point though, isn't it? I mean, a lot of this, the work that we're looking at here is, it's about the potential, but as we know, it's very difficult to measure what hasn't got there. You know, so something has been avoided unless there are other ways of recording or sort of measuring. And this has been a constant sort of challenge over sort of many years, measuring what hasn't got to hospital, you know, because things have been put in place in community or some of the sort of preventative interventions. No, that's a very good question. Okay, so before I go to Brenda, who's waiting patiently in the wings, I'm going to take a few questions from the from Slido. So I'm just going to share my screen so that we can sort of pick up a couple of the questions that we've got on here as well. So if I just go back to the beginning, there was a question right at the beginning, Sarah, which is about ophthalmology, and this was retracted further up because this was about outpatients, and we left it in because I know that people have said, are we going to be including outpatients in some further analysis of this as well? So if I could just, I'll move on from that one. but that is actually a question from me to you, Sarah. Will this be repeated? Because it is, the focus is currently on inpatients, but obviously there is that relationship with outpatients as well. Would you extend it to outpatients? Are there any plans to do that?
There aren't any current plans, but that's not to say that, you know, if there's a lot of interest in that we wouldn't look at it. There might be plans as well within other aspects of future work, more within our data science team, to kind of put perhaps more of this kind of data available. And yeah, no immediate plans.
Okay. And I've asked you that before, so if I just think if I keep asking, it'll just happen. You know, that's how it works. I got another question here. It may or may not be something that you can answer, but it says for community care, is access to services still an issue? Sort of digital inclusion training. Is this something that you've come across or have covered in this work or other work, or is this sort of kind of separate to the analysis that you've done for this report?
Yeah, it's kind of separate. This, I would say, is kind of a little bit more high level, but I think, you know, there is kind of work that we're doing that is more around this kind of thinking about access and some of those other factors. But yeah, it's not within our report.
Okay, thank you. So just moving on to this one, it's this one, and then I'll come back to the room. So we're saying, which potential benefits are you including in this work? So this is an interesting one. I think I know the answer, but it's a very interesting one. Have you considered, for example, the reduction in carbon emissions to contribute to NHS net zero ambition in those wider benefits?
I mean, we haven't within this work, but obviously this whole idea of shifting more to community, it's going to include some of that idea about, you know, reducing people travelling to acute hospitals and things like that, and reducing the kind of the pressure on acute services and obviously the resources that takes.
So it's sort of implicit in the reduction of activity, as opposed to something which was specifically measured. I know each trust has everybody has their strategies, so presumably to reach net zero, so presumably that's going to be sort of incorporated into those as well. So Brenda, have you got a question?
I was just wondering whether you've shown this report to healthcare professionals and asked their opinion about the perhaps for reasons, well, healthcare professionals and even patients maybe, and ask their opinion about why this is happening, each of these categories is happening, and then going back to use your data to see whether your data supports the possible explanation.
Yeah, we haven't done any of that at the current time. It was really just getting that first high level, let's just have a look at the data and look at the numbers. But yeah, I mean, that's kind of the next step really, is to understand why they're ending up there and the factors that are contributing it, because that's going to be super important to actually getting community services that meet the right needs for patients.
Absolutely.
Thank you.
Thank you, Brenda. Vishal, you have your hand up. Oh, you did. Yes, you have.
Yeah, that's great. Yeah, thank you, Sarah, for the very useful presentation on this. So my question was around, you know, when you're explaining around the ambulatory care, sensitive conditions and falls and everything like that, how would you, so is there any sort of logic around how you identify falls? Because we don't have, obviously, a domain where you can find out these NOMAD codes exactly for those sort of type of conditions on there. So is that sort of mentioned anywhere on the website or on your site? So
within our report, we touch on the kind of description of how that comes about, but we do within our methods, we link to the strategy unit's new hospital program page, which basically has well, there's two. There's the GitHub page, and it has all the Python code, which basically gives the different kinds of codes and inclusion and exclusion criteria that have been used. And there is also information available about kind of the rationale for those. So those are things that have been developed over, I was going to say before I came to the strategy unit, over like the last 5 years or more, that have developed this kind of this kind of category based on kind of literature and previous work that people have done. But that is the thing with these categories, is we've got them, but some of them are quite broad and they're not necessarily super specific, and they might not, some of them are still not quite targeting perhaps the right populations, which is why, again, we're very much saying it's just a proportion of the activity. And there actually is potentially more work to do to actually try and refine these categories to make them a bit more specific, and to make sure that people are kind of happy with that definition that we're using. But yeah, you can find out all the information about how they've been selected.
All of the codes are there. We've got all of the, I think, so all of those different categories, they're I'm trying to think the best place. I don't know whether they're all on the report, but all of the code is available, certainly, and they've been derived from sort of quite people will recognize, I think, a lot of the categories anyway, because they're on like performance management. What is the thing I'm trying to think about? NHS performance outcome framework sounds right. The public health performance outcome framework also sounds right. So I think some of these definitely hit a lot of those as well. So that they aren't going to be surprises for people. I think the difference is that there will be some that people aren't necessarily as familiar with, but also just using them in this way, combining them in the way that we've done. Quite often they get seen in isolation, so that double counting is massive. The way that we've grouped them together, recognized the overlaps, and being more realistic about the potential, I think is really valuable to people. Let's go back to Slido.
Sure, one question, sorry.
Yeah, sure, of course, sorry.
Late in there. How do you access the report?
I've popped it in the chat, and about half the people can't see the chat, so I will. I promise. There you go. So it's all being recorded. I will share the link in an email after today's session as well, and I'd also share that we also did a sort of a blog on this as well. I say we. I mean, I had nothing to do with this. I wasn't in the inspiration. I wasn't the analyst. I didn't pose the question, but I am telling you about it, so I do feel sort of connected. I will share the information you need to know. So that you can have a look at the report yourselves in your own time. And like Sarah said before I come back to the questions, genuinely, if you can find something that it could be improved, the way it's, based on what your experience, based on how you may have modeled some of this as well, looked into the future, please do share. Well, that's why we share stuff. That's why we share how we've done it, isn't it? So we can, it's not a test, it gives you the opportunity to really sort of unpick it and work out if we could do something a bit better, because we're building on it all the time, you see. So we do want to be able to building on solid foundations, and if we can improve them, we will. So just a couple more here before I have one or two other things to say. And I'm sort of bearing in mind that Claire might be having wanting to say a couple of words, so I need to save 2 minutes for Claire at the end. Well, I will do. There will be that opportunity. So look at these questions again. So we've got a question here. Do the zero length admissions, so we just had a question on that, account for spending over 12 hours in ED waiting for a bed? So if you what's the definition of the zero length? Or is this not clear?
So the zero length of stay is basically any admissions where they're not overnight, but it doesn't count specifically time in the emergency department unless they were admitted. I know different emergency departments work slightly differently, but so these are patients that were actually admitted, and so they were recorded as an inpatient, but then they didn't spend the night, basically. And they were admitted and discharged the same day.
Okay, great. There's my linking in question saying about ophthalmology. So I left that in so we could talk about the potential changes to the report. Someone is asking here how often we're updating this, and are they available on the Model Health platform? So is this, so you can do, I'm sure you can answer the updating, but do you know about the Model Health platform?
So these reports aren't on the Model Health platform, but it's readily available online with the link so that you can access it. Okay. So with this report at the present time, we're currently not planning to update, although we would like to. So we're kind of just starting to think about whether when we get, because we actually haven't got access to the next year of data yet, when we get access to that, we are thinking about whether it's going to be possible for us to update this. But I think, as Claire might mention, there are plans to do a slightly, basically this report would stay as it is, but to do a slightly different, perhaps more interactive version of this that would then potentially be updated.
Okay, so I do have that's useful to know, and I think very valuable, because what we like, we love to share our stuff, so anything we do we'll share back out there so people can use it. I'm sure people are doing versions of this themselves. Everybody wants to sort of identify this activity locally and see what potentially could be done in a different way, and being able to compare it as well is something that's really useful. I'll do one more question. Any outstanding questions, Sarah? If it's okay if I share them with you afterwards, and then I can include that in the email when I share links to your report and everything. So this person saying that it's really interesting. How does this analysis take account of structural changes in how hospitals are managed? Good question. For instance, we noticed that with the introduction of SDEC, is that how we say it? Some areas, for example, falls admissions saw a big increase. So change the way you do something, the numbers are going to be different potentially. How do you respond to that?
Yeah, so we do know there is data in there it is going to be variable between providers and between areas because of things like this. We do already know, I think, for some areas.
Yeah.
When we've looked at the report, they've got particularly high or particularly low, and we know, and actually some we've spoken to, and they know that there was changes in the way they coded something and things like that. So we haven't been able to take into account that, because obviously we're looking at data for the whole of England, and we can't possibly know what all the different hospitals and ICBs and things are doing. So that is a kind of a caveat and a limitation of the report, is we're basing it on the data as it's recorded. And it might be that some areas do have kind of differences or whatever, and then that's something that local areas will be able to say, okay, well, we've increased that, but we know why that's happened.
And that's something that's come up again and again on the new hospital programme. So obviously those 92 potential categories of mitigation. I'll just change the words around, Sarah, if that's all right with you. So those 92 sort of categories have been used to help plan those new hospitals, so how big they should be. But this is looking forward like 10, 20 years and 30 years in some cases. And so some of those sort of trusts are saying, well, actually, we've already made some inroads here. We've changed things, and this is what's happened already. And of course, planning the new hospitals, they're going to be saying, well, actually, we're going to do things in a completely different way. So I'm going to build that into those sort of models to predict demand. Okay, so we've just got a couple of minutes to go. I think just there's not really enough time for Claire to say anything, but I'm just going to say that the postman's gone. I was just going to say that this is, I think I said at the beginning anyway, this is sort of informing the next piece of work, which is going to be sort of an interactive model, I think, which is taking a lot of this content so it can be used in a sort of a more interactive way. And I think that's going to be something that we can share back here, hopefully in a month or so. So I will say thank you very much, Sarah, for sharing that with us. Really appreciate that. I'm just going to there's been lots of interaction and interest, and quite rightly so. I think it's such an important area which affects a lot of us. So if I just go back to my my other slides, which I've shut down, so you just have to bear with me just very briefly. I will just wanted to share something with you. I wanted to share this with you. See, if I sort of sing along the way, people don't know that I'm just being completely inept. Gets me out of trouble and into a lot more trouble. There we go. So I just wanted to share very briefly from the last minute. So in the next few huddles, this is what we got. The next one is going to be about, so Mike Woodall is going to join us, and we're going to be talking about coding ethnicity. You'd think it'd be you'd think some of these coding issues would be resolved by now. This has been such an issue for so long, but it's really important, and we're going to be saying how you can help us do that. Maybe a little bit of interaction in the next session. Then we're going to be looking at domestic abuse, which is something we haven't covered. So that's going to be with a colleague from the Isle of Wight who used to be local and then went overseas to the Isle of Wight. I've actually got your session on here, Sarah, as well, which is very remiss of me because I don't think you're going to be repeating it anytime soon. Okay, and there's lots of other ones as well. So, and there's just my final slide for you today is really just a reminder, really, that we still do training, and we do training and are hugely passionate about the training that we do. And this is one that we just did this week, actually. So this was a version of the leadership development for analyst training, which we've been doing for the last 5 years. And you know, you've seen Fraser, he's been here many times, so Stephen Wyatt. So this was something which was very well received. So please, if you are interested in, if you or your team are interested in this training, we can't provide this for free at the moment, of course, but please do get in touch. You won't be disappointed, I think it's fair to say. So just gone past 12 o'clock. Thank you, Sarah. Thank you, everybody else, for coming. It's always lovely to see you. And I'll see you again in a couple of weeks, everybody. So bye-bye.